Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. In this presentation we're going to review the shock syndromes. Okay, what's shock? Well, I'm going to use these classifications when we review it, but there are other classifications that can be used as well. This is just an overview. Now, shock is a syndrome, which is a predictable pattern, that's essentially characterised by decreased tissue perfusion and impaired cellular metabolism. It can result from trauma, too much heat, blood loss, allergic reactions, severe infections, poisoning, and severe burns. But essentially, there's an imbalance in the supply and demand for oxygen and nutrients to the body, to the cells. So, what is shock, if we define it? Shock is a major medical emergency and common after serious injuries. It's a critical condition that's brought on by a sudden drop in blood flow through the body. Blood pressure typically in an adult is going to be less than 90 millimeters of mercury. The circulatory system fails to maintain adequate blood flow and the delivery of oxygen, as we said, and nutrients to vital organs, the cells. What are some of the classifications? Well, the classifications that I'm using here are low blood flow and maldistribution blood flow. Low blood flow incorporates cardiogenic, hypovolemic, and obstructive shocks. Misdistribution or maldistribution or distributive incorporate septic shock, anaphylactic shock, and neurogenic shock. I like this diagram, so I've included it. So we have 4 types of shock here: hypovolemic, distributive, cardiogenic, and obstructive. Now, hypovolemic is associated with low volume, you've lost volume, which can occur in severe dehydration or hemorrhage. Distributive, for example, that can be anaphylactic, neurogenic, and definitely septic. You've got cardiogenic, which can be related to congenital heart disease, myocarditis, or certain arrhythmias like ventricular tachycardia, ventricular fibrillation, and even myocardial infarction, which we mentioned when we spoke about the acute coronary syndromes in previous sessions. Then you've got obstructive, which can be cardiac tamponade, can be tension pneumothorax, and it can be pulmonary embolism. And when we look at the 3 parameters, preload, afterload, and contractility, when we look at hypovolemic, you've got decreased circulating blood volume, so you've got severe loss of volume. Afterload will go up and contractility will go up as a result of compensation from the sympathetic nervous system. Distributive, well, typically here what will happen with neurogenic and anaphylactic, and certainly in the early phase of septic shock, you will get a decrease in preload. Afterload will decrease, contractility should be the same. Cardiogenic, preload will go up because of now congestive heart failure. Afterload will go up because of compensatory mechanisms from the sympathetic nervous system, and contractility will go down because the heart isn't pumping properly. Obstructive, typically now here, obstructive means that again, preload, there's not enough blood getting back to the heart. Something is obstructing blood flow returning. Afterload will go up, compensatory mechanism from the sympathetic nervous system, and contractility should remain the same. These are types of shock and consequences. If you look at the stages of shock, the 3 that I'm recommending are stage 1, compensated, stage 2, decompensated, and stage 3, irreversible. When you look at compensated, this is where now you've got signs of decreased tissue perfusion, for example, cold, pale, clammy skin, increased capillary refill time, more than 3, 4, 5 seconds, but the blood pressure is normal. It's above 90 millimeters of mercury systolic. Decompensated, you've got all the same signs of decreased tissue perfusion, probably worse, but you're hypotensive as well. Blood pressure less than 90 millimeters of mercury in an adult. Stage 3 is a progressive decline in the blood pressure and perfusion to organs and eventually failure and death. Stage 1, compensated. Stage 2, decompensated. Stage 3, irreversible. What are the consequences of shock? Well, again, we'll briefly review these. If we're talking about anaphylactic, related to allergic reactions, all your vital signs go up. But again, in anaphylactic, the blood pressure will be down. And with an anaphylactic or an allergic reaction, you typically get flushed, swollen, itchy skin, and with breathing, bronchospasm. Cardiogenic, heart is failing to pump, all the vital signs go up, but the blood pressure goes down. Cold, cool, clammy skin. Hypovolemic, you've lost a lot of circulating blood volume, so all your vital signs will go up, but your blood pressure will come down. Again, pale, cool, clammy skin. Obstructive, all your vital signs will go up, blood pressure will come down. Cool, pale, clammy skin. And take note, urine, your kidneys are a very good indicator as to cardiac output, because the kidneys require 25% of cardiac output. If they don't receive it because of a low blood pressure, you won't make urine. You'll become oliguric. With neurogenic, you've got spinal injuries or head injuries. All your vital signs go up, except your blood pressure will be low and your heart rate will be low as well. You'll have a bradycardia, because the sympathetic nervous system cannot help you here if you've got a high cervical injury and you're a quadriplegic, or you've got a head injury. And last, you've got septic, which all your vital signs go up. Blood pressure initially in warm phase of septic shock will be normal, maybe even a little bit elevated, but as you go into the cold phase, your blood pressure will go down. So therefore your skin will initially be warm, well perfused, but then when you decompensate or you go into the cold phase, you'll have pale, cool, clammy skin. So what are some of the diagnostic studies that can be done for shock? Well, there's no single study to determine what shock is. It depends on the type of shock, as you've seen. So history and physical assessment important. Blood studies, certainly. CBC, arterial blood gases. You can detect lactic acid levels. 12-lead ECG, chest X-ray. Hemodynamic monitoring. Doing vital signs. Who else contributes to the care of patients that are in shock? Well, it's a collaborative effort. So therefore, these teams can include specialists from cardiology, critical care medicine, heart failure clinic, anaesthesiology, cardiac surgery, nursing services, rehabilitation, perfusion services. Medical management, the important thing is to identify and treat the appropriate cause of the shock. If they've lost volume, hypovolemic, restoring intravascular volume. If it's now related to cardiogenic, as a result of heart failure, maybe some vasoactive medications like dopamine, epinephrine, even norepinephrine. If you require mechanical adjuncts such as left ventricular assist device, intra-aortic balloon counterpulsation, right ventricular assist device, biventricular assist device, then they may be indicated as well. But the important thing is to make sure that the vital functions improve until the patient recovers, and eventually then provide rehabilitation follow-up. Nursing management, well, we rely primarily on following the physician's prescription, but we follow the nursing process, which again means assessment, diagnosis, planning, implementation, and evaluation. And common interventions will include things like oxygen therapy, fluid and drug therapy, which have been prescribed by the physician. Now let's look at the shocks individually. Cardiogenic. Genic, where it originates from, cardiac, from the heart. So this is now a heart shock, which is a life-threatening condition when the heart suddenly can't pump enough blood to meet metabolic requirements, your body's needs. Most often, as we've indicated previously, it's caused by a myocardial infarction, where you lose 30 to 40% of left ventricular myocardium. It can be as a result of trauma or injury to the chest, which can also damage the heart so that it can no longer pump blood effectively. What's the etiology? Myocardial infarction, severe hypertension, cardiomyopathy, septic shock, obstructive shock, myocarditis, endocarditis, arrhythmias such as PVCs, ventricular tachycardia, ventricular fibrillation, or blunt cardiac injury, maybe as a result of a motor vehicle accident. The pathophysiology typically involves a spiral which results in ischemia, causing myocardial dysfunction, which aggravates the myocardial ischemia, causing myocardial stunning, and it doesn't work effectively, which essentially worsens the heart function, making cardiogenic shock more severe. What are some of the clinical manifestations? Anxiety, confusion, agitation, chest pain, tachycardia, hypotension, and narrow pulse pressure, indicating low volume, low cardiac output. Tachypnea, pallor, cool, pale, clammy skin. A slow capillary refill time, which is prolonged by more than 3 seconds, and not making urine, oliguria, or making less urine. Hypovolemic shock. Hypovolemic, low volume shock. And this occurs when you suddenly lose 15 to 40% of your circulating blood volume. The absolute loss of blood, which means you've absolutely lost it, can be as a result of hemorrhaging, severe vomiting and diarrhea, loss of a lot of fluid from fistula, diabetes insipidus, where you're passing something like 20 to 30 litres of urine every 24 hours, hypoglycemia as a result of diabetes mellitus, polyuria, or just any massive diuresis that you might have. Relative loss of intravascular volume basically means you haven't really lost the volume, but it's in the wrong place, which can be as a consequence of distributive problems like septic shock, anaphylactic shock, and neurogenic shock. And it's typically related to a term called third spacing, where the fluid is in your interstitial space. What's the etiology? With hypovolemic shock, the most common cause is blood loss. This can also be called a hemorrhagic shock, but it's as a result of heavy bleeding or loss of fluid from burns, or even severe vomiting and diarrhea. The pathophysiology is a life-threatening condition again, where you've got sudden loss of blood or fluids from your body, also known as low volume shock. And this results now in failure to meet metabolic requirements, anaerobic metabolism, lactic acidosis, cellular and organ dysfunction, and severe metabolic disorders. What are the clinical manifestations? Basically the same. Basically the same as what we saw with cardiogenic shock. When we look at neurogenic shock, now neurogenic shock is a little bit different to cardiogenic and to hypovolemic. But it can incorporate certain aspects of hypovolemic shock as well. So neurogenic shock, neurogenic means it's coming from the nerves, which typically means head injury or spinal cord injury. And it describes hemodynamic changes as a result of sudden loss of the autonomic nervous system tone, sympathetic nervous system. And it occurs when the level of the injury is above T6. And without sympathetic tone, this results in bradycardia, hypotension, and temperature dysregulation, which basically means your blood vessels cannot constrict. They dilate and you lose temperature. And often these patients take on the term poikilothermia, which means they take on the temperature of their environment. And if it's cold, they can't vasoconstrict. And if it's hot, they can't vasodilate. What's the etiology of neurogenic shock? Well, basically, car accidents, the most common, causing spinal cord injury and possibly even head injury, maybe as a result of falls. The pathophysiology, as we said, is now from damage to the spinal cord above the level of T6 vertebrae, and this results in victims suffering from low blood pressure, low heart rate, and temperature regulation. So these patients are hypotensive, bradycardic, and have temperature issues. And typically in the beginning, they will have warm, well-perfused skin, which is opposite to what typically happens in now low volume shock. What are some of the clinical manifestations? Exactly the same, except in neurogenic shock, you become bradycardic, and maybe initially you have warm, dry skin, and you develop what is called poikilothermia, which means you take on the environmental temperature because your body cannot regulate your temperature anymore because of sympathetic dysfunction. Now let's look at anaphylactic shock. Anaphylactic shock is really defined as a severe allergic reaction that results in hypotension and potentially life-threatening situation. We know it as distributive shock because they haven't essentially lost any volume, it's just in the wrong place. And this typically occurs when your immune system releases a lot of histamine, prostaglandins, bradykinins, heparan, which cause hypotension and bronchospasm. What's the etiology? The most common cause is food allergies, especially nuts and shellfish. And look, certainly medications that you might be allergic to, common one being things like penicillin, aspirin, maybe even allergies to bee stings, wasp stings, other insect stings, which results in now your immune system aggressively attacking whatever the allergen is. What's the pathophysiology? Well, the pathophysiology basically is a massive release of histamine from your mast cells and your basophils. Your basophils are important immunoglobulins or cells that are to do with allergies. And this can cause you to go into shock because your blood pressure suddenly drops and your airways become narrow and you can't breathe properly. Bronchospasm, a life-threatening condition. What are the clinical manifestations? Well, again, similar to previous, but you're very, very anxious. You may get chest pain. You may get facial edema, edema everywhere, angioedema, reddening of your skin, tachycardia, hypotension, tachypnea, wheezing, stridor, itchy skin, a rash. When we look at septic shock has two stages typically. Early, often referred to as warm shock. Late, often referred to as cold shock. But it's as a result of a severe systemic infection. And this is when bacteria get into your bloodstream, and this typically occurs after trauma or even surgery. Pneumonia can also be a cause of septic shock. It can also be caused by fungi or viruses, but typically it's bacteria. So typically septic shock occurs in the very old or the very young, but it can occur in anybody within a week who has a weakened immune system. And typically the most common cause, as I said, is bacteria. And it's the toxins from the bacteria that cause tissue damage. Let me reinforce it again. Septic shock results from infectious microorganisms in the blood that activate an acute and profound inflammatory response, causing hemodynamic decompensation. As it gets worse, decreased blood flow to your vital organs, brain, heart, kidneys, and it may even result in something called disseminated intravascular coagulation coagulopathy, DIC, that results in thrombi and bleeding that destroys tissue. Has a fairly high mortality, 40%. What are some of the clinical manifestations? Well, it depends on which phase you're in. As you can see, you've got warm, hypodynamic, cold, hypodynamic. And this can result in things like anxiety, confusion, agitation, hypotension, tachycardia. Initially, you can have a wide pulse pressure, which means a big blood pressure. And then eventually, in the cold phase, a narrowed blood pressure. You're breathing quickly. Stage 1 is warm, flushed skin. Stage 2, cool, clammy skin. In stage 1, you have a fast capillary refill time, less than a second. In the cool phase, you've got a slow capillary refill time, greater than typically 4 to 5 seconds. But in septic shock, there are two phases: warm, which eventually will become cold. Warm, maybe another term you could use is compensated. Cold, decompensated. When we look at obstructive shock, as it says, anything that obstructs blood flow getting into the heart or getting out of the heart. And this is a condition where obstruction causes the heart to have decreased diastolic filling, blood getting in, and decreased cardiac output, blood getting out. So therefore, decreased cardiac output, decreased tissue perfusion, failure to meet metabolic requirements. And as we mentioned previously, this can be in relation to cardiac tamponade, tension pneumothorax, hypertension, any valve problems in the heart, congenital or acquired outflow obstructions, which can be as a result of congenital heart disease. What's the etiology? This is a physical obstruction to blood flow. Obstruction that can occur at the level of the great vessels or the heart itself, as we said: pulmonary embolism, cardiac tamponade, tension pneumothorax, and these are all life-threatening. I've even included one there, the last one, a congenital heart problem, which is called tetralogy of Fallot. And in tetralogy of Fallot, you've got right heart problems there with an underdeveloped pulmonary artery valve. You've got a hole in the heart called a ventricular septal defect, VSD, and this will result now in obstruction to blood flow, in and out. What's the pathophysiology? Well, primarily it's caused because of an inability to produce adequate cardiac output, despite the fact that maybe enough blood is getting to the heart, but it can't get out. And can't get out might mean that it can't get to the lungs, and can't get out might mean it may not be able to get to the body. But the causative factors are located within either the pulmonary or the cystic circulation, or maybe even both. What are the clinical manifestations? Very similar to all the other ones related to cardiogenic and hypovolemic. So tachycardia, hypotension, narrow pulse pressure, cold, pale, clammy skin, slow capillary refill time greater than 3 to 5 seconds, not making enough urine, oliguria. When we look at the assessment, again, from the nursing process, we're looking at assessment being A, diagnosis, D, planning, P, interventions, I, and evaluation. But you can use the assessment being your history, and I've just chosen sample as being one of them, which relates to symptoms, allergies, medications, past medical history, last oral intake, and events. But again, the focused assessment will include vital signs, level of consciousness, urine output, level of consciousness, and peripheral pulses. Okay, that's the end of this presentation. As I've mentioned previously, after every session, if you find these Learn Shops of any value, please recommend them to your colleagues, your friends, whether they be nursing or paramedical, even medical, may find them beneficial. And subscribe. Take care. See you in another session.